So welcome everybody. I'm Rob Doubleday, Executive Director of the Centre for Science and Policy, and welcome to this, the 2025 Cleevely CSaP Annual Lecture. And it's a great opportunity for us at CSaP to acknowledge David Cleevely and his great contribution as the founding director of the Centre for Science and Policy, now 16 years old. And as we often remember, David, sitting at the front here, set up the centre with four kind of founding principles. The first was, if we're trying to contribute academic advice and expertise to help government, let's start by asking people in government what they want help with. That radical idea of trying to respond to the questions of the people we're trying to help. The second is that actually relationships are really vital and really important, and we can focus our work on building up relationships, building up conversations that support relationships of mutual trust and understanding that kind of crisscross the worlds of science and government and break down those barriers. And that's remained at the core of what we do. Also to think hard about experimenting, trying different things, try different ways of working, and fourthly and finally, understanding the importance of networks and the work that goes into building and supporting networks. And the work that's needed to be done in order to create the conditions for serendipity, for those opportunities for research in different domains and different areas to contribute to policy and different parts of policy. And although I don't think it's yet available for pre-order, I think by chance David has a book coming out that puts down some of these themes. So although when I checked on various online platforms this morning, it wasn't yet available for pre-order. Look out for that. Look out for that. So, and you'll be pleased to hear that CSaP continues to thrive, and those principles really shape what we do. And so this is an annual opportunity to get together in Cambridge and mark that. And not beyond that kind of relationship building policy fellowship work, over the last year or so, CSaP has been able, with support from HIFE and Research England's funding of the university through its HIFE fund and led by Nikki Buckley, to kind of develop a second pillar to our work, which is very much about supporting academics to build their understanding and capability to be able to answer those questions and support government. And part of that work, we've been developing themes. And three of the themes that we've been working on, particularly over the last year, one on national security, one on climate, environment, nature and sustainability, and one on health, and thinking about the relationship between research in health in all its disciplinary aspects and then actual health outcomes, what it means for patients, families, people, at the population. And that's a very important theme to us that we've been beginning to work on. So we couldn't be happier, we couldn't be more pleased to be able to welcome Lucy Chappell here to give our annual lecture. So as you all know, Lucy is the Chief Scientific Advisor at the Department for Health and Social Care, has been since 2021, so has seen a lot in not a very long time, and as also keeps up your work as a doctor, as an obstetrician in London, and on top of all that, perhaps most importantly to us, is a CSaP Policy Fellow, so also finds time to come in and support this development of exchange and networking. So I'm not going to say any more by way of introduction to Lucy, other than that we are so grateful to have you as part of the CSaP network, and we are really pleased that you've accepted the invitation to deliver this lecture, and what an important theme it is that you're going to be addressing tonight. And with that, hand over to you. Thank you.
Well, thank you very much, Rob, and to the CSaP team for inviting me to give this lecture. And I'd like to invite you to come on a journey with me through how we might think about science and research policy informing a future health and care system. This topic could not be more timely in what the Department of Health and Social Care is, but it really reflects thinking very much of the bridge between our academic, our research community, our clinical community, and this world that I've walked into of civil service, government and policy making. And it sort of reflects a journey I've been on as well. So I'm going to sort of set it into three parts, and part one is really sort of setting the scene And when I started writing this section, I was thinking about assets, but it became clear that some of what we might see as assets might also be seen as liabilities. So whilst I call out the richness of what we do have, I'm also very well aware that you might look at the same slide and wonder which side of the equation that is. Most Januaries I go to the JP Morgan Healthcare Conference, and Sam Roberts, who's chief exec of NICE, said to me that one of the reasons you go to San Francisco, which is not as glamorous as it might sound, is to see what other people think of the UK, because when you are in the UK, it's not always sort of obvious. And what comes out of sort of, what do other people care about is that sort of 1+3. So the science paired with that the NHS, the patients and public across the NHS, the workforce that we have, and the good bits of the system. Not everything's perfect, and I'm not going to pretend it is, but that model sort of helps us navigate through what is good, but also where we need to go further. So where's the science? Well, I think this is astonishing. This is the QS World Rankings for Life Sciences Medicine. And there we are, 5 UK institutions in the top 11. And even if you look at the QS World Rankings for all universities, it's pretty similar. And that's just an astonishing science base that we must not throw away. And obviously, when you look at things across the other side of the Atlantic, it becomes even more important that we don't throw this away. And clearly, we do quite well on Nobel Prize winners. And here I am standing in Cambridge. And as you all know, we could just put Cambridge in the league table and it would be doing pretty well too. So by lots of different measures, our science is looking good. Let's look at science publication and citation metrics. Currently, we're 3rd after the US and China. But then if you look at the field-weighted citation on the right, we come top. So it's not just about, as ever, the input. It's about the outcome and the outputs and the impact. How do we do on investment? So this is a very topical. Some of us in government are in the middle of the spending review and going into live conversations with Treasury, which always keeps this front of mind. And with our previous government chief scientific advisor, Patrick Vallance, now as a minister, we are well placed to have science represented, but we still have to make our case on a weekly, monthly basis to Treasury. So you can see the investment by government on the top left and by private non-profit on the right. And that translates into about just short of 3 billion for government from our latest figures in health research, and about 9 billion from the pharma sector from recent years. So we've got good investment, but when you look on a world league table, there are others with greater investment. So it's what we do with it that counts. And in fact, if you look at UK R&D spending by the OECD comparisons, you can say we're sort of pretty middle of the table, pretty close to average. And you might, Patrick himself has talked about, what percentage do you need to be at for R&D spend to be really driving growth? And at a time when in government we are talking clearly about economic growth, we are repeatedly making the argument that R&D must be seen as a driver of growth. The second area we have is our patients and the public. And I take this snapshot of an average day in the NHS because sometimes we forget what we are sitting on. So there we are, 1.3 million GP appointments a day. So when it feels like you read the headline saying you can't get an appointment, that's not because we're not doing a lot of work. It's because the demand is, as we all know, higher than ever. But that's an average day in the NHS, which just shows both what the demand is, but also what this single system looks like. We have a universal coverage with single payer. And there are pros and cons of that have been rehearsed on multiple occasions, including in the run-up to the election. And it becomes an asset if we use that universal coverage with single payer as if we really leverage what that represents. And yes, we've got foundation trusts, we've got secondary care, primary care, community care, which feels in a lot of flux. But one of the questions is, how do we turn that into the asset that it should be? And actually, one of the challenges is that universal coverage, as we know, does not equate to universal healthy life expectancy. So on the left, you see healthy life expectancy in the pale blue bars, topped with total life expectancy in the dark blue bars. And I call out the lowest deprivation on the left-hand side, where the healthy life expectancy, if you live in the most deprived decile, is 50 years. as opposed to your healthy life expectancy if you live in the least deprived decile of being 72 years. And that's quite a staggering gap. On the right, you see it by geography. I've picked males, currently age 65. These are the ONS statistics. And you see really widely varying healthy life expectancy by that geography, which will intersect, obviously, with deprivation, with ethnicity, and with multiple other factors. But actually, the patient asset goes further, because where I stand, I see the huge opportunities of patient involvement in research. And that exists through numerous ways. And NIHR, which I'm chief exec of, has done this both through its patient registry, be part of research, which built on the vaccine registry and COVID, but also with really important colleagues such as the Association of Medical Research Charities, who reach into that patient group through patient support charity working in ways that I really see the benefit of. And also how the Health Research Authority, which is the regulator that looks after ethics, how they work. So there's a whole raft of ways that we can reach that patient voice and really think about what we do with that. And then my last point about that patient asset is about health data. And I have chosen on purpose to use the slides from Understanding Patient Data, because unless we really sit that as a patient asset, not as our asset, it is owned by the people, then we will miss the point. Because if we don't do this with trust and engagement as the starting point, we won't have any asset there. So for me, it's about understanding how patient data is held and controlled from that lens, not from the exploiting lens. So the next part of it is the health and research workforce. I include this. This is a slide of me at St Thomas's with one of our patient groups that we run a research active clinic, and we've really looked at how the pregnant women who attend our clinic in Lambeth become part both of shaping our research, designing our research, disseminating it. And it's an incredibly rewarding experience. And if you work in somewhere like Lambeth, that's got to be on an equitable, representative basis. So that slide reminds me of what that feels like. The workforce across the NHS has had a considerable amount of scrutiny, both during the COVID pandemic and subsequently. And you can look at all sorts of metrics. You can look at where we are, the NHS long-term workforce plan looked at where we are in relation to other countries in terms of doctors per capita or nurses per capita. And then you can look at the composition of the NHS workforce, because it's not just about the doctors and the nurses, it is about all of the people involved in health and care. And we should always look around and say this cannot be a medic-centric view, otherwise we will have missed sort of the reality of how our health and care is delivered. In recent months, Patrick Chinnery, known to many of you in Cambridge, has chaired a group that really seeks to look at what the Medical Schools Council called out as, and it was called Reversing the Decline. So they've noted that the clinical academic posts, so those funded by universities working jointly with the NHS, have been declining. And particularly if you think about it as a percentage of the increasing workforce. So you can see on the left that declining proportion of clinical academics, both in primary care and secondary care, and how that equates to a widening workforce gap, which will sort of makes everyone ask, where is our next generation of research leaders? But some unpublished data from NIHR shows that if you look, I've called out two of the groups, the doctors and the nurses. So this shows you the number of academics per full-time equivalent, 100 full-time equivalent. And that second bar where I've highlighted the nurses reminds you that we have this enormous nursing workforce with a really small proportion who are academic. That isn't because the nursing, the evidence base behind nursing is less important. It's just that historically we've had a much stronger pipeline for doctors and nurses. And the argument at NIHR is that we need everyone in the room when we're delivering research if we're going to have the health and care system for the future. But we have another bit of our workforce, which is the National Research Delivery Network. So previously our Clinical Research Network, our CRN, and now our Research Delivery Network, newly launched last October. Why does this matter? And it's because that research delivery network workforce, we fund around 11,000 people across England to deliver research. So rather than the old system where you would hire and fire and rehire with your next grant, which is what they do in Australia, they were just saying this is transformative. And we've had it for a while across NIHR, and sometimes we forget what we are sitting on. This is a gold mine. So what does it enable? It enables a competitive offer to industry. We've recently gone out with mobile research units to reach our communities in different ways. We're making sure we're in primary care. And it is the workforce that delivered the recovery trial and so many more of the COVID trials. So we just pivoted them in early March 2020 to delivering COVID research. So what's the outcome? The outcome is we had over 1 million people recruited to research last year. I'm shortly to get the cut of data for 24-25. A quarter were in primary care. A quarter were recruited to commercial research. So sometimes there is a narrative peddled about sort of the doom and gloom. I'm suggesting that it's not all as doom and gloom as it looks, and we are sitting on these assets. But the fourth one is the health research system, because there are a couple of views. Can you do this through single points of accountability? Well, sometimes things in government need that single point of accountability, but the huge majority of what I do is system. We've got John Clarkson here, who has taught me what I know about health systems, because if you see it from a very sort of siloed view, you'll never think about the interconnectedness, which is absolutely crucial. And actually what I will come back to is why this system matters and why you have to see it through that approach. The system requires health spending, and so health spending requires you to look at research through the wider lens of health spending. And you can look at it in a number of ways. So just on a very basic level, the NIHR budget is around 1.6 billion this year. Everyone says that's great, Lucy, but actually what's the total DHSC budget? And it's about 200 billion. So the proportion of the DHSC R&D spend as a proportion of the total DHSC spend is still under 1%. And you might argue, is that enough? Is that enough for you to see the changes that we're looking for? But actually on the right, as many people know right now, the budget for health and care is also being stretched by what's happening with defence, and that's having a particular pressure on our ODA budget, our global health budget. And you can see on the right all the pressures on the system, with the top line being for social protection, so Department of Work and Pensions. And there's always going to be these pressures and these trade-offs against other bits of government, with us really trying to make the case for health spending. When you try and map the system, and I haven't drawn my own, I thought about going off to try and draw the research system. I went back to David Cooksey's report in 2006, because David Cooksey was one of the first to try and draw this out. And actually, when I went back to the report, do you know what? It's pretty similar. So he proposed this very much as a sort of left to right pipeline, and I'll come back to say, is that where we should be? And also talked about some of the bridges, the gaps in translation that we need to bridge, and where you get this idea of valleys of death. So unless you bridge those gaps in translation, then things come to a halt, and it's harder to get them moving through the system. More recently, this is the NHS England Accelerated Access Collaborative Map for Healthcare Technology. And what does this look like? Well, if you're a company trying to bring a piece of health tech into the UK, it probably looks quite complex. Actually, if you look into it, it's got a lot of the components, and across the top, you can see that the clear stages in bringing health tech. And actually, do we want a Wild West? Not really. You probably want evidence of effectiveness. You want evidence probably of cost effectiveness, safety, approval, all the sensible things. So what you see in the media is either we're far too slow at putting health tech through this pipeline, or you say, well, if we took away those sensible gates, would it be Wild West? And the answer is it's got to be a balance of both, But you can understand why I struggled when I was thinking, shall I draw my own map of the system? Because this is what it can look like. So what about the other key bits of our system? So the MHRA, the Medicines and Healthcare Regulatory Authority, is one of our key areas. And if you sort of do a temperature check on MHRA, there's plenty of good things that they've done. So ILAP, the Innovative Licensing and Access Pathway for drugs, and IDAP, which is similar for devices, is really trying to tackle some of those multiple hexagons that we showed in the last slide. But also, when I came into post, I was really aware, just in August 21, what MHRA were doing, particularly both on mutual recognition. So should companies have to go through separate recognition routes with every single different regulator across the world? And where could MHRA, particularly once we'd left the European Medical Agency, where could they be leaders? And one of the answers was in that in 2021, thinking about immunobridging. So that's where you ask, if you're going to license a COVID vaccine for a new variant, do you have to go back to square one, or can you use laboratory testing to tell you whether that COVID vaccine can be licensed? So real opportunities, and particularly through the Access Consortium, which is a group with Australia, Canada, Singapore, and Switzerland, and other mutual recognition partners, such as the Europeans, Japan, and FDA, as to how MHRA can be a real asset in the system. And similarly, we have an asset in the Health Research Authority, which is the bit of the system that provides ethical approval. It's what you want to know is happening before you sign up to clinical research. And in fact, HRA and MHRA have had a combined review in pilot and more recently as just standard. So you don't do a sort of linear sequential model of moving your drug or device through the system. You go to both, and they consider the same data at the same time. And interestingly, HRA as a national research ethics body has been in place since 2016. And so, again, when people are sort of taking pot shots at us, it's sometimes worth remembering what we have in place, whereas in many countries, you still go to institution by institution, known as IRBs, institution review boards, and get separate ethics approval at each site. So I often have the stats from USA, Australia, and Spain thrown at Lucy, how could you do better? So in the USA, you typically have an FDA process for your drug, which is around 30 days, followed by that ethics approval, which is about 7 weeks. So there's lots of people sort of comparing apples and oranges when they're saying, how are you doing across your systems for research? Interestingly, in Australia, they're introducing the one-stop shop, which is a version of what we have had in place since 2016, and it is in sort of pilot phase, pilot testing now. So again, they've got ways of sort of accelerating some of their research, but in other areas we are ahead and we've got more tried and tested methods. I also have everyone repeatedly telling me that it takes 100 days to set up a clinical trial in Spain, and I should point out they've got a royal decree. I am hoping for a royal decree in the UK. I would love one. And the image on the right reminds me that I'm just waiting for that moment to pop up and ask King Charles when we're going to do the same. Because you can do all sorts of things with a royal decree, and we don't have one in the UK. And as I'll come on to talk about, we don't even have R&D metrics mandated at any level in the NHS. So we are doing things by goodwill, largely, not because there's a royal decree. So if you want to look at our comparator data, this is from the most recent year available, which comes out every June or July in the Life Sciences Competitive Indicators. And you can see that at 273 days, we're clearly not as competitive as we would like to be. And the US is doing better than us, but other countries are sort of around there, and there is room to improve. So that's a sort of overview of our 1+3 assets. Always sensible to start with the science, and then 3 other areas. Can we look at some examples of where this works? And I'm not going to pretend that these are all absolutely fine. I've just picked a couple where we can just say, you know, what's happening. Because I'm saying that these 4 ingredients, when they are all aligned, can result in good stuff happening. So one of the ones I'm going to pick is paediatric cancer. And again, there may be people, specialists in the audience, who ask, who think that I'm providing too rosy a view, and I'm aware of the reality, but just we'll talk about why I picked this one. So if we look at the science, paediatric cancer is actually quite low volume in terms of other cancers in older people, but you can understand why at many levels it's an area where there's a real push to understand the science. This was a Business Connect report from UKRI Innovate UK, where it really looked into where there were opportunities and where some of the barriers in moving the science forward. They recognise the gap, so 300 cancer treatments licensed around the world, fewer than 10 specifically designed for children. And as many of us, an obstetrician, I hang out with paediatricians and neonatologists, children are not small adults, is what we remember. And in fact, it was one of the moves why the European Medical Agency introduced the Paediatric Investigational Plan, the PIP, which requires new drugs to be considered for use in children. But actually, you know, in this not straightforward population, it's not, as I say, it's actually quite low volume. There are potential opportunities for UK businesses, and they could see reasons for optimism in this area. There are initiatives like See Further, which is the join up between LifeArc and Cancer Research UK. And there is work across some of our leading biomedical research centres, for example, the Institute for Cancer Research at the Royal Marsden, and also on an international level where the Zero Childhood Cancer initiative in Australia has really said we're not going to crack this by the UK on its own, and we shouldn't do because we've got amazing scientific collaborations. So work to do on the science, but also plenty of reasons for optimism. But actually, what that is matched by is a really strong patient-parent pull for reasons that I think will be obvious. If it was your child with cancer, you would really strive to get the best treatment. And I have worked with the Tessa Giles and brain cancer mission around brain cancer more widely. And the ability of a group like the Tessa Giles Brain Cancer Mission to convene, to bring together these the multiple players in this area is absolutely critical. And they can set those visions of both sort of immediate 10-year horizon and longer term that really sort of matches and marries up to the Australia Zero Cancer. But actually what's really striking is how far parents will go to get access to new treatments. So we struggle to actually, in the UK, understand what percentage of our patients take part in research. And if I ask someone from CUH here, they might know, but then again, they might not. Because actually counting how many of your patients take part and the aspirations of the new Cambridge Cancer Hospital and the new Cambridge Children's Hospital is very clearly got that in mind. So if you say that on average about 5%, but I think that's actually quite generous, you then look at various studies that have assessed what is the take-up of research in this population, and there's a paper on the left describing that half were determined to be eligible, and then a vision to say, you know, maybe it's 1 in 5 who take part. If I had 20% of the pregnant women in my antenatal clinic taking part in research, I would be delighted. And if you think about where we could go with 20% or 50% of participants who walk into our doors, whether in primary care or secondary care, taking part in research, think how fast we could make new advances. But actually, as I've said, it's also about the workforce, because if we don't bring our workforce with us, you will have all the patient and parent pool that you want, but they will be turning up and demanding access to new treatments, and you have to have a workforce who are ready to offer that. So it's got to be that married up. So we have the experimental cancer medicine centres, the ECMCs, which have an adult network and a paediatric network, and that harnesses that workforce who just become really familiar with the processes by which you ethically and soundly offer research to children at a really critical time of their lives. But actually, I've certainly consented pregnant women in labour to trials. There is no group where it is not ethical to consider the option of to consider offering it. I'm not saying you have to force people into it. I'm saying you don't coerce, you can offer. And then that needs to be aligned with the system. So, for example, this is the ECMC paper on new regulatory routes for cancer treatment. Because if you're going to stand up that parent and patient pull, and if you're going to get your workforce excited, you've got to have the mechanism for your regulatory pull through. And so it needs all aspects of the system to be working. And at the end of it, what's the point? The point of all of that system integration is to get the outputs and the impact that you want for the patient in front of you. And when I recruit when I offer research in antenatal clinic, one of the things I say is that a good number of the treatments we are now offering in pregnancy have happened because pregnant women sitting in that chair before you have taken part in research, and it is now integrated into clinical practice. So I make it real that if you take part, you might be doing it broadly altruistically for the greater good of the field progressing. So new life extending drug treatments, maybe thinking about the side effects, that the new drug to stop children and teens losing hearing after chemotherapy, and then also making sure we've got a pipeline as a funder to say, well, what's on the horizon, and that's the launch of our Brain Tumour Research Consortium. My second example is pandemic therapeutics, which I was part of both in before I came into this job, both as an obstetrician and as an academic and a clinical trialist in the pandemic. And one of the roles I had was as the national pregnancy lead for the recovery trial, where I saw at first hand some of the enablers and the barriers to this. So where were we back in March 2020? This was a roundup from the FDA, which it said it was going to give emergency use authorization, EUA, for hydroxychloroquine. So the point is we just didn't know what was going to work and what wouldn't. And even as sort of in June 2020, they were writing about, you should consider hydroxychloroquine, ivermectin. And I remember sitting on the calls with Peter Horby and Martin Landray, where they describe everyone being horrified that they were going to be considering dexamethasone, because didn't we know that it was unethical and unsafe to use dexamethasone? And Charlotte Summers, who's an intensivist in the front row, remembers that time when the intensivists were just guessing, based sometimes on informed sort of thoughts about what was going to work and what wasn't. So what did we do? What came to the rescue? And the answer is research. And the ability of the UK to stand up those really large trials. And I remember from all sorts of perspectives, and there are people in this room who lived through this and just gave so much of their time and effort to getting this swinging into action, where it was the recovery trial, the REMAP-CAP trial, the UK CSaP, which looked at what drugs should we firstly repurpose, and then secondly, stand up anew. And we sort of lived through it as scientists and researchers, sort of thinking it was normal. It wasn't. What we were doing was miles ahead of the rest of the world, and sometimes we forget that. One of the other things it did was democratize access to research for the first time. So when we did our weekly recovery trial meetings, we looked at every single unit in the country. The recovery trial, which I'm most familiar with, went into every single secondary care. Some kicking and screaming, just to be clear, some of our units and some of the big teaching hospital units did not find it easy just to say, yes, get behind a single trial. And there, again, there are estimates of what proportion were recruited. So 10% roughly, but if you look at the second paper, it was between 3% and 80%. So we had, what was it about some units who could offer research ethically and get 80% sign up? And what were the clinicians doing in the other unit where it was 3%? And one of the things I was doing was persuading not just the obstetricians to offer the research. I'm just using the word offer. Not saying you had to do it, but asking pregnant women and their families to make the decision. And the comments I got back, so the obstetricians are broadly on board because we've been doing drug trials in pregnancy for years and we know how to do that. Some of the intensivists were saying, I wouldn't let my wife take part in that trial. Why? Because it's better for her to die of COVID? What is the rationale behind the gatekeeping that goes on and where healthcare professionals think that it's their place to make the decision? So we really pioneered safe treatments being considered for pregnant women so that they were not left behind. They were not included in any COVID vaccine trials, to be clear. They were excluded from them. And as a result, we deployed a COVID vaccine that had not been tested in any pregnant women. So we had women on our intensive care unit dying in the pandemic. And that's one of the hardest things I do in my job. So the difference between offering research and not offering research is whether pregnant women will live. But we also had a workforce behind us. How did that happen? The UK CMOs, 4 nation CMOs, wrote out and said, go and recruit. We then changed our landscape, so we pivoted that workforce to delivering research and saying, this is what you need to do. We looked at the systems like the panoramic study, which was recruiting in primary care, and we delivered trials as we hadn't seen before. This was molnupiravir, where we said, of course, you can't turn up and come and see someone because you've got suspected COVID. So we introduced a completely different model of centralized recruitment where you rang up and then you got your pills sent to you in the post. So we adapted at pace and scale. And then we went into care homes in a way that we hadn't done before. And this was the Vivaldi study set up by Laura Shawcross at UCL, who looked at getting into care homes into an area that was really relatively research naive and making research happen. What was the result? Well, across the system, we recruited at a pace and scale the like of which hadn't been seen before, either in secondary care for a whole bunch of our trials or in primary care, Panoramic being the fastest recruiting primary care trial. But it needed the system, it needed MHRA, the Health Research Authority, who convened ethics committees, who met in 48 hours and gave a readout, and it was done safely. We were not jeopardizing safety. All of those were maintained, and we still made this happen. What was the impact? So as many of you will remember, in June, so just 100 days after the start of the lockdown, there was a CAS alert, which is to say, and I remember the results coming in and saying, you will now treat with dexamethasone. And that happened within 24 hours of the results coming off and being checked. And the impact, the UKRI report that reported on the millions who were saved by that. And just as an addendum, the inclusion of pregnant women in the trial meant that it went live for pregnant women and children at the same time. Have we learnt? Well, this is the 100-day mission, which is to get drugs, therapeutics, and vaccines within 100 days of a pandemic. And this is the scorecard that you can go and find on the 100-day mission website. We've learnt some lessons, but not enough. And we could go further and look at what is it that drives that. So there is one crucial thing, which is the investment in foundational science. The reason we had developed that COVID vaccine and got it up and running is because of 10 years, 20 years and more of investment by UKRI and NIHR in the underpinning science. And that's what really made a difference. So it's not 100 days from a standing start. We don't get a vaccine through all of the safety checks, but we can when you've got that foundational investment. Is it all rosy? So I've mentioned my own area of maternal health. And frankly, we've been admiring the problem for quite a long time. Nick Fisk, back in 2008, who is a professor of obstetrics at Imperial, who I trained with, wrote this paper where he said only 17 drugs are under active development for maternal health indications. So that was against 600 in the pipeline for cardiovascular health, and it's a half of the number under development for motor neuron disease or ALS. And that just shows the sort of the gap. We carried on admiring the problem. I wrote this paper with Anna David in 2016, where I talked about what we might do better. And then the drug drought in maternal health was published around 4 months ago, saying that we are still struggling to get some of these areas. In fact, I've had the fortune and joy in my own academic career of being in an unusual position of taking a diagnostic test through the entire cycle of translation. So up there on the top right in my PhD, I happened to measure a substance called placental growth factor and show that it was different in women who got preeclampsia compared to normal pregnancies. And as it happens, I took it through a cohort study, a randomized controlled trial of single testing, a randomized controlled trial of repeat testing, and then onwards, and it is now implemented across the NHS, across Europe, and it's now recognised in, it's now just been approved in the US. And that's been done with the help of the Health Innovation Network, who have really ensured that we do that last part of the cycle to actually get it to pregnant women across the country. The images from the top left are our unit at Guy's and St Thomas's and the high dependency unit, which consists of a bed and a pillow in Ndola, because our latest work is in getting PLGF to where the burden of disease is highest, which is in the global south. And interestingly, the place where we are moving forward with point of care testing is not the UK, it's the global south. And much more of our work is happening across Zambia, Sierra Leone, India, where they actually want and need a point of care testing, whereas it's much harder to do in the UK. So in the last part of my talk, I'm just going to say, what do I think would make a difference? Can I link all that science with policy, which is what Rob invited me here for today? What levers do I think we have? And you can have a sort of various view on what these levers are, but broadly, I think I've got policy levers, I've got statutory or regulatory levers, I typically have some financial levers, and the fourth one is equally important. It's using engagement and often persuasion to make a difference. What are we trying to do? Deliver science with impact, to really drive patient and public engagement, to inspire our health and care workforce, and I think to change the system and perhaps to change the incentives across the system that really might help make a difference. So when I started in my government journey, and when I was writing this talk at the weekend, not last night, well, maybe last night a bit as well, I went looking for, like, what's an image of policy? And the image that comes up is this one. And this is from the Government as a System Toolkit, the Policy Lab. And I think this says a lot about why policy can be quite impenetrable. So this is probably what I felt like in my first month, my first year, and there are still some days when I feel like this is what policy looks like. And it's no wonder that we don't make it necessarily accessible for our colleagues in the academic community. So my plea to maybe CSaP is, could you draw me an image of policy that doesn't look like this? Because what do we do that actually shows us what our policy levers are? This was a post from Patrick or the Lord Science and Technology Committee, where I was really struck by him setting out his areas of priority, which he expects us to enact through some of those policy levers. And it plays to something that I think is really important and interesting, which is this tension between discovery science and curiosity-driven research alongside this prioritization. And it's something that has been live through most of my time, and we'll come on to think about how that tension plays out. So I think one of the key enablers and one of the balancing acts that both UKRI and NIHR have is it only going to be done by prioritization? The answer is, I think you leave people behind, and I don't think that's the right model. So it should neither be entirely blue sky nor entirely priority driven. And I think that balanced foundational science investment with additional focused research is probably one of the ways that we need to do it. One of the parts of this is investing in critical technologies. Patrick, as GCSE, was headed up the UK Science and Technology Framework, and after a really interesting market analysis, these 5 critical tech were chosen: AI, engineering, biology, future telecoms, which you might actually think about as connectivity, which so just as relevant to me in health as it might be to transport or anyone else, semiconductors, which sit across much of our tech, and then quantum technologies as an emerging area. And I think that if I reran the market analysis, I might come up with perhaps 5 slightly different ones, but these 5 areas would repeatedly come to the top as being critical. So we've been very clear in health about how we choose to invest in this. For example, we've just launched our AI trial to tackle breast cancer screening. So applying what is AI being a much more mature technology in a health sense, and really where we need to think about AI in a number of different areas. We've got more AI in our supermarket loyalty card than sometimes we do in bits of health. So really seeing about where we should push for adoption and really distinguishing between AI just embedded within a system versus AI being the intervention. So all sorts of thinking across many bits of government on that. Quantum tends to split people. Some people think it's about to be the next best thing, and other people say we've had quantum around for ages. And I'm actually in health talking about quantum sensing, but obviously there's other types of quantum, and really saying we've invested with UKRI through the Engineering Physical Sciences Research Council on quantum hubs for health, and really saying, well, what is that going to deliver? And you might get the sense of it's going to swamp us with data over how can we actually use it intelligently. And then thirdly, engineering biology, which is broadly speaking already all around us. But Angela McLean, as current GCSA, is doing a particular push on engineering biology aspirations and making sure we continue to be world leading in Eng Bio. But I've talked about this tension between and these trade-offs. So this is the Health Research Analysis Report published under the auspices of multiple funders, but particularly led by the MRC, where our health research spend is divided into 8 areas, sort of a left-to-right pipeline, as I showed earlier. And you can see the sort of overall blocks of spend, and then you can see the trends. Everyone has got a view as to where they would like their money put on those blocks. So some people want it more to the right-hand side, some people on the left-hand side. We have to try and please everyone. And then you can dice and splice it by areas. So top is generic health relevance, cancer and neoplasms, infection, and then you have some orphan areas at the bottom, skin, ear, congenital disorders, blood. So the question is, everybody wants their area funded, and then if you try and match it to disability and need quantified through DALYs, then everyone has got a further idea. In fact, if I happen to tell you that, for example, stillbirth has had a 0 DALY, that's not what a parent will say to you if she loses a baby. So there are some anomalies in how we quantify disability that may mean that it's not entirely perfect. So we try and match this, but it's not always perfect. This recent paper by the MHRA was really interesting because it showed the pipeline of clinical trial submissions received between 2019 and 2023, and we met the MHRA team recently to say, let's keep this updated. Because what you look at is a few areas of what is on the horizon. And the answer is the top one is cancer. Again, areas that I think you'll all recognise, metabolic and endocrine. We all know what's coming down the clinical trials for areas like obesity. And interestingly, again, to counter the narrative, commercial sponsors represent 85% of the total submissions. There is a view on whether we are being equitable towards our older population, and represented in 67%, and then pregnant and breastfeeding women, just to get my point in, 1% or less. So these perils of prioritisation, right at the bottom you can see I've highlighted pain, barely or even recognised. So what about areas like pain or urinary incontinence? Do they ever get the recognition they deserve? So 28 million adults affected by chronic pain, and yet look at that clinical trial pipeline. 14 million affected by urinary incontinence. Who do you think is out there championing urinary incontinence? Not many people. So before we just say it's really clear how we do prioritisation, I think we need to think about those who might otherwise be left behind. And actually, it's compounded by the sort of well-described demographic trends of ageing and multiple long-term conditions where things don't fit into neat buckets anymore. This is from the OBR, the Office of Budget Responsibility, looking at our changing demographic trends that we all see forecast, and then seeing it not just in terms of single conditions, but how are we going to play out that clinical trial pipeline when we actually need to think about the intersection between different areas. So really, some of the science we should be thinking about is going back to those valleys of death and asking that we think about joining up the ends of that pipeline to make the translational cycle. So you can go from T0, your discovery research, through your translational steps into humans, into patients, into practice, into community, and you can look at what bridges do you put in place, both as funders, through policy, financial levers that ensures that we get the join up, so that when you get your implementation of your intervention into the community, into practice in the community, you work out who does it work for, who doesn't it work for, and you go and find your discovery scientists in the next door building and get talking to them about how you're going to develop that further. And it's not just by collaborating with people in the next door building, it's also collaborating on international and global partnerships. We should not exist in an island. So both the work that we've done with India, with Australia, and also many partners in low middle income countries that really drive this forward. The second area I talked about is patient and the public through building trust. And this is both engagement, but also I just comment on financial levers. Why? Because you get better patient outcomes. So we all know, particularly sitting in Cambridge, that if you embed research into your healthcare systems, you have better health outcomes. So why doesn't it make sense for every secondary care, primary care, community care to be research active? So lower mortality odds, that's a hard outcome on death. Gross value added by the contribution towards those access to new treatments and more confidence in staff. But it's absolutely underpinned by patient trust. And if you look at both sort of trust in scientists, the public want us to improve public health, top right. And they want us to think about how we communicate, because we will only win that trust if we work out how to communicate with patients about science, and that includes about uncertainty. So this recent paper last week from Nature talks about, it's not that we're really losing trust, it's also about how we think about influence at the moment. So these are 3 lessons that came out so clearly from the pandemic. Work with local sources, cultivate greater literacy, and make scientific communications not the privilege of the elite, but really think about how we get out more widely. And if you look at how that trust in health marries up with empowerment, you can see that very strongly. But we really have to think about how we tackle health misinformation and disinformation. And this paper from Jessamy Bagnall, who's one of the Lancet editors, really sort of, how is this funded? Not well funded across government generally, but we need to step into this space, acknowledge the role of social media, think about the patient-centric. Almost all of our health and care system is system-centric. It's designed for the benefit of the doctors and the nurses. Think about the areas left behind where we're seeing the misinformation, disinformation move in, and think about how we understand the evidence base for tackling this. We have really good trusted partners, such as the Wellcome Trust, who have had decades of interest where we could take this on. And also think about research to tackle inequalities, not perpetuate them. So we've, at the NIHR, used a whole range of strategies, including making research inclusion a condition of funding, not an afterthought, but you have to do it to get our funding. And being very focused, for example, through our maternity challenge, specifically to tackle inequalities, or the health determinant research collaborations where we work with local government. We've also been very clear about our commitment to public involvement, both through the shared commitment to public involvement and through a whole suite of resources, and then asking the public to get involved through Be Part of Research. You can go and sign up. I hope it will be on the front page of your NHS app shortly again, and through working with the large consented cohorts such as Genomics England, Our Future Health or Biobank. The third area is inspiring the workforce. Why? Because a more sustainable workforce, again, it is better for your workforce. So more likely to apply, they want the research, and it reduces burnout and increases satisfaction. So my sort of visionary view is that if you work in health and care, you can only be in one of 3 states. You can be research aware and support the offer to patients and the public. You can be research active and do the offering, or you can be a research leader. There is no state called being a research blocker, and I don't think it should exist. So with the NHS long-term workforce plan, we really hope to see better recognition of research. Aradazi, in his fantastic technical annex of the multi-page technical annex, talked about a lot of the trends in workforce and the challenge with the reduction in productivity. But what if we turn that on its head and said, what if you saw research, innovation and training absolutely embedded across the health and care system so that that drove our workforce rather than being an add-on? And we need to do our bit, and certainly are across UKRI and NIHR, to develop those research leaders so that, again, we've got plenty of people who are there to lead. So the proposed model for the clinical academic pathways from Patrick Chinnery's report looks at simplifying that and really asking all the funders are coming together to say we should be clear about our research leadership career pathway. Again, not just for doctors, but also for all of our health and care professionals. And finally, how do we change the system incentives and rewards using all of those leaders? This is the hardest bit, and I speak as someone who's been in the system now for a few years. Of course it makes sense. You get better outcomes across the system. 7.4 billion of GVA added to the economy, 1.2 billion added for the NHS, better outcomes on CQC. Research engagement improves those processes. So why is it so hard? I wonder whether we need to think about when you have incremental steps versus the bold steps. And I've put up Mass General, and clearly I put up CUHP as being where I think we need the bold steps, where you look at the vision and the ambition of both of these organisations in two Cambridges and say, you know, as we say in the NHR, research is everybody's business. So you don't make it an afterthought, a special thing to do in a particular place. You make it what everyone does. So, you know, the ask of the Cambridge's ecosystem is, can you make that happen so that when I say what percentage of patients are offered research, you can say all of our patients are offered research somehow, somewhere. We have statutory levers already. This is the Health and Care Act. You have to facilitate or otherwise promote research, but I don't know that we're seeing this enforced. We have regulatory levers. We can enact this through MHRA, and we can get those regulatory levers through, for example, the Regulation Innovation Office to help us. We can see where it can work, so the Health Data for Research Service and AI regulation can help us here, but you start to see how many bits of the system we need. And we have policy and financial levers that we enact. So 10 days ago, my weekend was rather taken up with writing this PM announcement on the Health Data Research Service, but also on turbocharging medical research, as they like to say in the headline, to go from 250 days, which I showed you earlier for approvals, to 150 days. That's the what. Now we have to ask, you know, about the how. And the how is through the UK Research Delivery Programme. So I talk about incremental versus step change. We've done it twice before. We did it at the start of COVID. We saw a step change in getting the whole of the research ecosystem to act differently. So it's not impossible to do. And then when we were recovering, we saw a slower step change, because on the right you see that we had only 27% of our studies post-COVID pandemic delivering to time and target. And over 9 months, we restored that to over 80%, and it's stayed there ever since. And that was a whole range of policy and financial levers. But research has got to be for public and patient benefit and for economic growth, because if we go on that twin track, we are more likely to get the system aligned to working. Where do we need to go? We need to really think about how we're going to go from firefighting, which is where we are in the moment, to fire prevention. Because we've been through the pandemic, we are in the post-pandemic. But if you look at the OBR curve on the right, if we don't start thinking about fire prevention, we will go up that curve inexorably. So we need to ask, what everyone is saying in government is, how do you bend that curve? What is it that it would take? So our Secretary of State would like to think it's through the health mission and the 10-year health plan, where we want those goals. We want the what of timely access, fewer lives lost to big killers, and fairer Britain tackling inequalities. And the how is the shifts of hospital to home, analog to digital. And to bend that curve, you need that treatment to prevention. And that is why I ask, how are we going to get science and research underpinning that policy? Because for me, you're not going to have a health and care system in 10 years that looks any different unless it's underpinned by that science and research. We know that we've got wide support. We've got Wellcome Trust talking about the fourth shift from research to reality. We've got ABPI, the Association for British Pharmaceutical Industry, really clearly saying go for that embedding research, similarly with the Association of Medical Research Charities. Is it rocket science? Well, sometimes it is, and there is occasionally you get moments where you can bend that curve. So, for example, look at what the tobacco and vapes bill is going to do for smoking in this country. But there aren't many times when it looks like that straight line. Most of the time, my life and those of many policymakers looks much more like that messy place on the right, where we have to ask, what can the system do? So as a government research funder, it's not just enough to sit in that context, because we're in the middle of that health and care system and that political context. I think I've lost count of the numbers of Secretary of State that I've had since I started. And the messy reality is we've got 7.5 million people waiting for elective care. And so how are we going to be part of that is those transformation steps on the right. As scientists and researchers, we need to be responsible as much as the services. So I finish by saying I think we can use and have to use science policy to change those outcomes. It is the NIHR's mission to improve the health and wealth of the nation through research, and I remain absolutely committed to that mission. Over the last 12 months, we've been really clear about talking about how we deliver impact, inclusion, innovation and investment to change those outcomes. Thank you very much for CSaP for the invitation to talk about this. I will mention Chris and Sally, and particularly Chris, who has been my boss for the last 3.5 years, who has probably taught me more about policy than anyone else. The network of chief scientific advisors and allies across the system who have been kind. My colleagues at King's College London who have put up with me as an ongoing academic, my colleagues at the maternity service at Guy's and Thomas's, and the unsung heroes, of which there are a number in the audience, including particularly my private office who are there. And if you don't know how amazing the private office are in government, I can tell you later. And my family who are also in the audience who put up with me. Thank you very much.
Thank you so much, Lucy, for an amazing sense of the world you're in and the challenges you face, and the sense of what is working and the positive future that's possible, even though it sometimes feels like a squiggly line rather than a straight one. We just have a short amount of time for questions or comments, and then we're going to have a reception where there'll be a lot more chance for further interaction. So we'll just take 15 minutes or so, I'm afraid. We've got mic runners. So what comments are allowed as well as questions, but both either comments or questions need to be short. And where shall we begin? Yeah. Thank you. Yes, please.
Hi there. Thank you so much. That was fascinating. I'm a life scientist. I now work in policy. And you spoke a lot about involving patients. I think that was a really key part of your messaging. My mother's come to me and she's received the offer on multiple occasions to take part in research where they would draw blood and then do exome sequencing, genome sequencing, etc. But looking through the privacy policy, often the data is held by private corporations. When 23andMe just collapsed recently, there was a lot of questions around what happens to that genomic data. How do you build trust with the public when they don't necessarily know how their data will be used moving forward? And do you see that as a barrier to involving patients?
So I think you're absolutely right. And unless we get that communication embedded in all communities, so not on a selective basis, we're not looking for a subgroup of people, our research has to be representative. But we've got to get that right across all stages. So for example, if you involve patients in the design of those consent forms and the information leaflet and the what are you going to do with my data, then you will not have you will have fewer of those trip ups. But you're also right about what we've really learnt on the Health Data Research Service, which is what's the point? The point is to get benefit for patients and the public. It can also drive economic growth, but we should also always remember what the top line is. And what we learnt in the pandemic particularly was that, you know, that concept of leave no one behind, which we did okay, but we didn't do well enough in all sorts of areas. And the inequity of that cannot just continue forever.
Got two questions here, unless anybody wants to come in specifically on that comment. Sarah, can write down, I think it's on this comment, and then we'll go.
Hi.
And introduce yourself as well.
Thanks.
Sorry.
Pippa Bryce. I'm the lead for research and impact for the integrated care system in Cambridge and Peterborough. Just wanted to touch on your comments about better communication, including to the workforce. So the nice thing about doing research is we get to be the good news story that cheers people up at the end of a hard meeting or a hard day. But it's so difficult to translate that into an appreciation about the need to embed research so that it's not just a separate good news story, it's everyday practice. Do you have any ideas how we can work on that cultural change?
So that's a really interesting one, because if you go back to the pandemic where it became everybody's business, you suddenly saw that curiosity and so I think there's a sort of a two-way. Sometimes the system makes it hard. So, you know, have you done your GCP training? Well, frankly, you don't need it for the majority. So I look around this room and there are R&D leaders in this room, and we all need to take our bit of responsibility for removing the unnecessary barriers. Because actually, when most people are inherently curious, but if we invent ways to make it difficult and special, we are much less likely to take our workforce. So for me, one of the campaigns we ran in NHR was Your Path in Research. So how do you take that first step, and how do we demystify it and then draw people in? Some of the most amazing visits I've been on, for example, to a care home in Telford, where that curiosity came from the care home staff. They were seeing, they asked, how do we reduce urinary tract infections that end up with our residents in hospital? So if you see it from the point of view of that workforce and that curiosity, I think we're there. But you're so right, there is much more that we need to do.
Hi, I'm Christina Cornwell. I work for an organisation called the Innovation Unit, and we support kind of complex social innovation, particularly to tackle health inequalities. That was brilliant, so thank you very much. And you already painted a very complex kind of picture, so I'm really sorry that I'm going to bring in a bit more complexity and potentially ask a bit of a mean question. But you talked up front about the big challenge around the vast inequality in healthy life expectancy, which of course we know is mirrored by the sort of economic activity, people's ability to engage with work, which obviously also has a big impact on economic growth. And of course, a lot of the drivers of that sit beyond the health service and certainly beyond life sciences. And I just wondered, given the kind of three big policy shifts that the government's committed to, the extent to which the research community and infrastructure is kind of able to gear up to taking a kind of broader sphere, including social sciences, and thinking about both different solutions, but also, you know, the implementation science and the kind of conditions, both the policy conditions and the kind of regional conditions to kind of make that work.
It's a brilliant question, and there's two sort of routes. One is thinking about our role across government, so and arguably the mission-led government concept, if we can actually make it stick from a policy point of view and from a treasury and spending review, that's exactly what we should be doing. So they are getting all of us as chief scientific advisors, and therefore with R&D budget, to say, how would I, as Chief Exec of NHR, contribute to the Safer Streets mission? Because where do we see the intersection between, you know, opportunities with, it doesn't just sit in education, you've got to get that bi-directional sort of conversations. What if we think about violence against women and girls, mental health, addiction, across the Home Office, Ministry of Justice and ourselves? And the other way of enacting it is with UKRI. We have got Ottiline in the front row as Chief Exec. And under UKRI and the research councils, I can reach out to our economic and social researchers in my field, but I'm even more effective if I go into a partnership with ESRC and say, let's bring our communities together. So, for example, we did a partnership with EPSRC, Engineering and Physical Sciences Research Council, on engineering solutions to independent living for older people. because that was bringing together different research communities and different, that interdisciplinary work that actually CSaP has been championing in other areas, to say, don't try and solve this by sitting in your health ivory tower. You will, many of these things, particularly around the social determinants of health, do that. But the other thing is, in the room, we've got people from an ICB basis and local authorities, where we should be seeing that mirroring of what is happening in practice with what is happening in research. When we launched our Health Determinants Research Collaboration, they had to be held by a local authority. And the excitement from the local authorities about, like, you want to come and ask us what to do was really palpable.
Thank you.
Hi, Sutha from Flagship Pioneering. We're a venture capital fund that's based in Boston. We have $12 billion of committed capital to life sciences discovery, and we're really excited about the UK opportunity. What's the best way to work with NIHR to unlock some of this great potential?
Well, somebody offering 12 billion of committed capital is always exciting. So we have a whole range, and one of the things is, how do we have a coherent offer to industry? Through several different routes. We have a landing page, but we still could go a lot further. So there's a couple of ideas. One is that you have a single front door, but a better idea, I think, is that you have a courtyard, which is where we say, come in and we will help navigate you to the right door, depending on who you're trying to connect with. So, for example, we do some very strategic partnerships, like our ones with Moderna and BioNTech and Flagship, where we're saying, what have you got to offer and what can we do? And, the vaccine trials that I mentioned with Moderna were a really good example of where they needed to deliver a seasonal vaccine, and we mobilised the right bits of the system, because you don't need to interact with all our system, you need to find the right people. So depending on, if you want an early phase experimental medicine cancer, early phase cancer trial, then we'll direct you to the ECMCs who do this. But if you want to do a phase 3 population study, we connect you with the right bit. So it sounds like we need to meet afterwards.
Great, we've now got quite a few people, so I'm going to redouble the request for short questions or comments and perhaps brief responses. Yes, please.
Hi, my name's Ian Broston. I work for Innovate UK, part of UKI. I'm Deputy for Innovation Funding. You mentioned regulation a lot today, and my team, my former team, actually responsible for setting up the Centres for Excellence in Regulation, Science and Innovation that have just launched. With co-funding from OLS and MHRA. I was wondering whether you think there's a lot more investment required in the regulation side, so we can speed up trials and other parts of the regulation process. I think we've got 7 centres related to health alone that are in those early phases. So I wondered if you thought there'd be more investment required in regulation and how that might help not just drugs but also medical devices in other parts of the system.
So briefly, I think it's easy always to say more money. I would actually argue that we need our money better spent, and proportionate regulation, so the new clinical trial regulations that are coming in, aim to be more proportionate. You cannot put everything through a one-size-fits-all. So you need both the operational delivery to run smoothly and proportionately, and we also need to be much more future-focused. So one of the things that I'm particularly passionate about is looking at our different ways of drug-device digital combinations, where the UK could choose to be a world leader and saying, come and show us, to the previous questioner, come and show us your drug-device digital, because I don't see many regulators being really front-footed about that. And of course, considering integration of AI or what is going to come down the line on quantum or other eng bio. So for example, cancer vaccines, which are right now quite personalised, or have we got the regulatory model for highly personalised vaccines, and are we doing that right?
Thank you. Yes, please.
Hi, hello. Thank you for a really interesting talk. I'm Sonia Marjanovic. I lead the Healthcare Innovation Portfolio at RAND and led the piece of work that RAND did with Wellcome on research to reality. Some of it is published, some of it will be published soon. I was really struck by the shifts you showed, and then the underpinning need for research and innovation to support all of those shifts. And I think we've learned that in the academic community and in the research funding community, that's very well supported. So the question I have is, on a scale of 1 to 10, how confident are you that research and innovation will feature prominently in the 10-year plan by those who are writing it?
Sounds like you're reading my emails and my inbox. as to where it is. So we've got the 10-year plan and we've got the life sciences sector plan. And plans are great. It's what you do with them that counts, because if they stay on a shelf, then so it's not so much just the plan, it's the commitment of everyone to deliver that plan and to really see. I mean, I would be completely visionary and say in 10 years, I would like us to reimagine our health and care system so that if you build it on research and innovation and training, you are constantly future looking and improving. How do you think we're going to get out of a 7 million backlog? It's not by doing the same thing as we've always done it. So we should use that as the driver, the poly crisis, to actually say, isn't it more urgent than ever? So, and I will come back to where we are looking for all of those really forward-thinking systems, of which I think Cambridge should clearly be one, to say we're not just going to carry on doing the same thing.
Thank you. I'm going to take three more comments or questions, starting here. Thank you.
Thanks. So Rachel Cooper from the Food Standards Agency. Lucy, that was a brilliant talk. Thank you. So really interested in how your view of how government could be quite expansive in terms of what it thinks will have an impact on the health system. So how do we get other areas across government, and for me particularly thinking about the food system and DEFRA, to think about the kind of long-term impacts and preventative agenda to support on health?
So when I showed those three goals, the what, it was timely access to the NHS, which is pretty much owned by us, prevention of the big killers, which is a sort of hybrid, and a fairer Britain, which has got to involve so many other government departments. And I think we are going to do it best on a quid pro quo basis, which is that we would all get further if we help each other rather than staying in a very sort of single departmental model. It is not, the spending review process and the allocation of departmental budgets don't necessarily make that straightforward. So we will probably get through SR2 right now, come out the other end in June, and then say, how do we use the working level engagement, whether it's across FSA or DEFRA, or to actually make this stuff happen? And so we just have to accept the sort of the policy making or the financial allocation, which sometimes by necessity, and how much Treasury tell us otherwise, is done in those buckets, and then say, but the way you're going to execute it is by choosing to do that cross-government working. And the fact we've got Cabinet Office colleagues says a lot in the audience, because that is how we need to work, for example, on biosecurity. We're never going to do it in a single departmental, by pulling up the drawbridge. So we need to make the other way of working better than the status quo. And you could say that for the rest of the disruption that I was showing. If I want that system change to happen, I have to choose to make the new way, the disruptive way, much more appealing than the status quo, because human behaviour will tell us otherwise we will default to the carry on as usual.
Right, we've got several questions lined up, which I'm afraid I'm going to have to disappoint you, because we're just going to take one more in the interest of time, and then we can have more convivial kind of conversation in the reception. But final question to you, please.
Thank you very much. Thank you for that insightful and enlightening talk. My question is a bit more of an interest. I have.
Who are you?
Sorry. My name is Aliko Ahmed. I'm the Regional Director of Public Health for East of England. So there's a bit of selfishness in my question. East of England represent about 10% of the population of England. And we are contrasting. We have two challenging issues. On one hand, we have excellent academic institutions, brilliant research, as you had described. On the other hand, we have one of the worst outcomes and most challenging areas in the whole country. In terms of multimorbidities, in terms of outcomes, you see, how do you support us in bringing the two together? There is a big bridge between the excellence of research and scholarship and what we see in terms of population impact. We've been trying to work together, and I think your diagram that shows the T4 to Z to TO, which is the translation, is where the elements of impact can be maximized. What sort of support can we get in doing that to bridge that excellence with impact?
So actually what you describe is what we also see in other areas, and in fact Chris Whitty in his annual report called out where you have coastal communities. We are seeing a move of our population, particularly as they get older, because those seaside places are really nice to live, but they are also much less well served by our health service. And if you look at the coastline of East Anglia, you can see exactly what's happening. So you get some really interesting demographic patterns which we need to address, otherwise we are sleepwalking into that. You often get a big mix of high deprivation next to low deprivation on a coastal basis, where you are underserved with health services in the wrong place. So what's the answer if you're Cambridge in the middle of East Anglia? Is how to rethink things as your sort of, I say mini system, it's about 5 million as you all know, but you can't just be doing things for people within a mile of Addenbrooke's. You've got to be saying what is your regional footprint as your day job, as you know from your day job, and how do you translate that learning from where it is working to reach the populations? And the answer is a whole range, and it actually comes back to what we've heard, which is the challenge is not owned by a single bit of the system. It is owned by multiple bits of government. So that join up between local authorities and secondary care and primary care. One of the questions, and to pose to people here, why is it so hard to get those people in hospital who are ready for discharge back into the community? And how do we use, putting Pippa on the spot, how do we use the ICB model to address that join up so that it's not seen as my problem or your problem, it's seen as our problem, but with our solution? And I think there is a whole set of opportunities, both on a sort of micro level, but also on that meso-macro level to do that. I'm quite sure Rob will say, let's pick that up over drinks.
Yeah, I will say both that, and thank you, Alika, for that question, which is something that I mentioned at the beginning, that CSaP's trying to develop a theme and stick at some kind of question on this in this area, and I think that's exactly the kind of theme we will want to pick up. And so I can use this as a plug to say that we have our annual conference coming, which will be a kind of an overview of all the kinds of areas that CSaP's been engaged with, which will be in London in June. So do sign up and join us for that. Also, please join us for a reception, but before doing so, join me in a very sincere and warm thanks to Lucy for a stimulating and provocative and exciting and daunting lecture. Thank you.